And I'm going to introduce our speaker. So, Dr. Nicole Patamunuch is a General GI Program Director at Seattle Children's and the Associate Program Director for the Pediatric Gastroenterology and Hepatology Fellowship Program. Her clinical interests include TEF and EA patients, PEG tubes, and all gastroenterology topics. Her hobbies include juggling her 3 children and training a show dog. I'm not sure those are hobbies I would consider, but certainly sounds like something that keeps you very busy. So with that, I'm going to turn it over to Nicole to give our talk today, and thank you all for coming.
Welcome, everyone, and thank you for having me. It's a pleasure to talk to you about constipation today. The goals of the talk are really to review when is it worrisome and what are some of the things to think about in more serious constipation, and then really to go over an overview of where to start with your patients on how to give them at-home regimens. Okay, so how do we define constipation? Everyone has probably shown your patients a Bristol stool chart. This one I like because I oftentimes describe it as food to kids because that's the easiest for as a universal language for all of us. First I talk about, skipping days without stooling is definitely constipation in an otherwise normal child who's eating daily. And even if they're having daily stools, it's important to emphasize that if they have anywhere between Bristol 1 to 3 stools, that's still technically constipation. Because oftentimes families will say, no, my child poops every day and it's perfectly fine. Does it look like pellets? Does it look like a bunch of pellets squished together? For type 3, do you see lots of cracks in the poop and it's whiter and harder? And then 4 is really, does it look exactly like a hot dog? That's the easiest way that kids know is it's that caliber and it has smooth and has no lines on it, really to know this is the perfect poop. They can often have Parents can often report that every time they eat, they have pain right after, and that's very alarming for parents. But this is what I tell them is this is most likely a more severe gastrocolic reflex, which is exactly what the body should be doing. It's just trying to move the stool along, which can be pretty significant pain for those that are constipated. Parents can also report bloating and distension that tends to be worse at the end of the day. So they start off with a normal looking belly in the morning, and as the day goes on, it gets bigger and bigger. And that all is very consistent with constipation. They can also have cramping with dysbiosis that you see in constipation. And patients also with those type 2 and 3 stools that are larger and they're straining, they can see bright red blood on the toilet paper and water that's in the bowl. It's helpful to really ask very detailed what blood they're seeing, because if it's just on the toilet paper or just in the water, and it can actually be very impressive to them because it's so bright colored, that's a very small amount of blood and likely with some sort of anal or rectal fissure from straining or a large hard stool, versus diarrhea loose stools with blood that's mixed in with the stool, which can be different. When should you be concerned? I've kind of made a list here, but we're going to talk through them in more detail in the following slides. So constipation since birth, and we have more significant concern for Hirschsprung's disease, urinary and stool retention issues together, and you have abnormal findings on their lower back, failure to thrive with global growth delay, any sort of perianal lesions, a kid presenting with severe chronic vomiting associated with weight loss, family history of celiac disease, and also fecal incontinence. And we'll talk more about each one. So constipation as a red herring or Crohn's disease. I want to spend some time talking about this. So this is definitely not, there's a lot of you can sort of describe in here that could be like a lot of the kids that you see in clinic, but these are very unique kids. So they may look like they're constipated because they in general have not been eating well. So their oral intake has gone down significantly, or they have been avoiding regular intake, so that's why they're not stooling often. And then the other piece is that there could also be withholding behaviors, which is why they are constipated. The inadequate caloric intake, I'll spend some time skipping down to the last bullet. That can be when kids have small bowel Crohn's disease, when they have significant thickening of their terminal ileum, it almost acts like a partial bowel obstruction. So it can present as a kid who every time they eat, they have severe pain, or every time they eat, they vomit soon after. And because of that, they have weight loss and constipation. How do you differentiate the kids with Crohn's disease versus the kid that just has chronic vomiting and weight loss? The key is the labs. Kids with Crohn's disease with this type of presentation have very significant anemia. They have elevated inflammatory markers that are not subtle. They have a significantly elevated fecal calprotectin over 500. Their albumins can also be low, versus we have kids that we take care of that have chronic vomiting for months and weight loss, and their labs are perfectly normal. So the normal lab kids, I would not worry about Crohn's disease. And if you have any concern that their upper GI symptoms can be Crohn's, the stool calprotectin is very helpful. The other kids with withholding behaviors that could be Crohn's, so some kids, and this is rare, where they have perianal disease, and that's how their Crohn's disease presents. And because of pain, they have withholding behavior. So they don't always describe it. So you have to specifically ask, does the child have habits of sitting abnormally, like there's something that's painful at the bottom? Have they noticed anything unusual on their perianal exam when they're cleaning their kiddo? And obviously, doing a physical exam in clinic is really helpful. One thing I wanted to go over is that we sometimes get referrals for hemorrhoids, but I would say in pediatric, hemorrhoids are very unusual and uncommon. So by and large, you want to assume that there's something else. We do see hemorrhoids in pediatrics when kids have pretty significant straining. True hemorrhoids, as you know, are dilated veins. So they will have appearance of being bulbous and have a purple or blue hue. And when the straining resolves, the lesion goes away. When it's something that's fixed, that doesn't have that change of color because of a dilated vein, it's unlikely to be a hemorrhoid. So we want to worry about perianal skin tags. So perianal skin tags typically have an appearance of thin flaps of tissue that can be asymmetric and at various parts of the clock, if you're thinking of the anus as a clock from 12 o'clock and on. And I say versus hypertrophied perianal tissue because, and this is very important to distinguish, some kids who have a long-standing history of chronic constipation where they have large hard stools can have some hypertrophied tissue that is just a soft mound of tissue that's usually at 12 and 6 o'clock because that's where there's the most tension when they have straining with these large hard stools, which looks very different than perianal skin tags. Another thing is perianal skin tags, because they're associated with Crohn's disease, they can be erythematous, they can get inflamed, and they can be painful and also drain mucus, for example. So they look very different. In addition, other features of Crohn's disease are perianal fistula. So that's actually any sort of openings around the skin around the anus and recurrent abscesses that you see around the perianal area. This could all be associated with Crohn's and present as withholding. Okay, so let's talk a little bit about Hirschsprung's disease. So this is classically described as explosive stools on digital exam, but that's not always what you're going to see. Sometimes these are patients that can be diagnosed later in life, and so not always early in life, but in those infants, you would see that explosive stool on digital exam. On an x-ray, you can also see a paucity of air in the rectal vault, as well as dilated loops of colon on the KUB. When KUBs overall look reassuring, it is less likely to be Hirschsprung's disease. These patients also have growth failure and global developmental delay. There is two entities. There's long and short segment. Long segment involves larger portions of the colon, and this one can present more severely, whereas the short segment disease can present often later in life and be missed. And sometimes these children are not diagnosed until 9 or 12 years old because it involves a shorter segment of their colon. In these patients, we have been trying to coach providers not to do contrast enemas as a screening tool. And the reason why we avoid contrast enemas as a screening tool is because it is not a helpful screening tool. It can miss it, and it can also overcall any concerns. And we typically recommend um, scheduling an anal rectal manometry for kids that were truly worried about Hirschsprung's disease. And I'll talk more about an ARM. So this can be done in as young as 3 months old. An ARM is used as a screening tool, and in order for us to refer the patient on to the next step, which is to get a biopsy. Risk factors for Hirschsprung's disease include siblings with Hirschsprung's, children with syndromes such as Down syndrome, cardiac disease, multiple endocrine neoplasia, Mowat-Wilson syndrome, Waardenburg syndrome, and congenital central hypoventilation syndrome. So there's definitely a genetic component to Hirschsprung's disease, which is why you see it associated with some of these syndromes. As I mentioned before, the gold standard for diagnosis is a rectal suction biopsy or a full thickness biopsy. Of note, our surgery team can do in-office unsedated rectal suction biopsies up to 0 to 6 months old in patients that you're concerned about. And for 6 months and older, they recommend doing a fully sedated, full thickness biopsy. And what you're looking for on these biopsies is an absence of ganglion cells. To go on to what ARM is, again, that's anal rectal manometry. That is something our motility specialists perform, and that's Dr. M. Bartsumian, and we have a new motility specialist that's joined our team, Dr. Kresselup. Of note, they've divided it by Dr. Enzo Bartsumian has more interest in the colon, and Dr. Kresselup is more interested in the upper GI tract, but they both have specialized training in these techniques. So with ARM, this is a diagram on the right, and it's basically a short catheter that's inserted. This is not a painful procedure. It can be a little uncomfortable. So it's nice to be able to talk parents through what this usually entails. They insert the catheter and they inflate the balloon in the rectum. And normally you should have a rare. What they're looking for is the rectoanal inhibitory reflex. If that's absent, that suggests that Hirschsprung's disease is likely and they would be referred on to get a biopsy. You can still have a rare with spinal lesions. Other indications for ARM is specifically to rule out or rule in Hirschsprung's disease. You can also look for different types of defecation dysnergia. You can look for internal sphincter achalasia, which is very rare. You can help differentiate between retentive and non-retentive fecal incontinence, and you can test for rectal hyposensitivity and hypersensitivity. It's preferably done when a patient is awake. This can definitely be limiting. The information you get from an awake study is much better than when you provide sedation. With sedation, you can get limited info. So it is important to coach families that this is a short 30-minute test. It's not painful, but we do need some cooperation. For infants, oftentimes infants can be bottle fed and have a catheter in for a short period of time and get all the information you need. So it's not hard to do. Another thing to consider is anal rectal malformations. There are 3 different categories. One is cloaca, which is when the urinary tract and rectum share an opening. Fistula, which is when the rectum connects to another portion of the parts of the body like the urethra, the bladder, the vagina, or the perineum, as well as imperforate anus, which is when the rectum and anus are not connected at all. They're completely disconnected. The one I wanted to point out that is hard to tease out and is more likely to be seen in like the continuity clinic in general pediatrics is the fistula, the perineal fistula. So for imperforate anus, for example, this is something that likely would come up in the nursery because the child's not able to stool and could get sick, and so usually that's diagnosed there. The other, like cloaca, you would see stool leaking from the wrong places or urine leaking from the wrong places. Fistula, which is what I highlighted up here in the upper left, could actually look like a abnormal appearing anus. And as you can see from this diagram, behind it is the true anus with the sphincter and the muscles, and the rectum actually exits out of the skin. How do you know that this is the case? Um, it will not, what looks like the anal opening is not symmetric. You're not seeing a normal puckering. Oftentimes, if you were to try to get a reflex by touching the perianal region gently with, a Q-tip, you would not get see an anal wink. That's one way. And then another thing that this could present as, this could commonly can present as a otherwise perfectly healthy infant who's growing and doing excellent, and then with the introduction of solid food, they have um, nonstop stool output that seems to be uncontrolled. And really, what's happening is with the introduction of solid food, when they have a lot more stool that's more formed, they basically become impacted and the stool leaks around it and there is no control. And so parents will say, I don't know why, but my kid is pooping nonstop throughout the day and there's a horrific rash. This is not an uncommon presentation. So taking a very close look at the anus and looking for symmetry is really important. And if you have any concerns, I refer to peds GI or peds surgery, and we can get them in clinic and do an exam. Another way, if we're having a hard time accessing services, another way is cross-sectional imaging. A KUB is not going to be as helpful to differentiate the anatomy down there. A contrast enema is something that you can consider if you're not sure where things are going. And then cross-sectional imaging like CT of the pelvis is another tool. So I mentioned I go over these asymmetry noted on perianal exam with a bulge to one side, stool in the urine or around the vagina, and urine exiting from the anus, constipation or fecal incontinence, and just a careful physical exam, CT of the pelvis, contrast enema, and referral to peds GI or surgery. Spinal cord lesion. So this is also uncommon. This can present as back pain, weakness or numbness in the legs, difficulty walking or running, scoliosis, loss of bladder and bowel control, or foot deformities. Tethered cord is something that we think about in clinic when we have kids with very difficult to treat constipation. There's a couple of types. There's congenital, which is spina bifida. There could be trauma or injury, a previous surgery in the area, or even tumors or cysts. We do not, the workup for this is a lumbar spine, MRI of the lumbar spine. This is a lot to put our patients through because a lot of patients need sedation for an MRI. And so it's really something I try to use only if it's something that I'm significantly worried about. If spinal cord lesions are an issue, they should have other neurological issues. Like I mentioned, they could have other motor deficits, but also should have bladder retention issues as well. So these usually go together if there's a spinal cord lesion. If there is no history of injury or trauma or surgery, again, that cuts out some of that differential, and we're really looking for something that could have been missed. The trick about tethered cord, and that's hard, is it does not always fix the constipation issues, even if there were to be a repair. It is something that after time, if they're having all of this plethora of issues, it's important to know, but they can still have ongoing constipation and bladder issues, even if it's repaired. Celiac disease. So that sort of sums up some of the surgical issues and some of the GI diseases that we don't want to miss when we're treating constipation. So those are important to think about. Other things that we think about when we've kind of gone down that list and say, it's we think less likely to be Hirschsprung's, not concerned about spinal cord issues, it's not Crohn's disease. We also want to rule out celiac disease and thyroid issues. So a little bit about celiac disease. Most of us know it as a disease that presents as abdominal pain, vomiting, diarrhea. But interestingly, in a few patients, it can present with very severe and difficult to treat constipation. It's not a large portion of our celiac patients, but it is something we test for frequently in our constipated children. Interestingly, when they've done studies on when they put these patients on a gluten-free diet and when symptoms resolve, Constipation is one of the last symptoms to resolve in both adult and children and can be very, very difficult to treat, even though they've been on a gluten-free diet for a long time and their TDG has gone essentially down to normal. So it can be a long-standing symptom. In addition to the GI symptoms, they can also have what looks like an eczematous rash that does not get better with typical things like moisturizing and avoiding detergents and using hydrocortisone creams, it can persist. Also asking about a family history of celiac disease because that is significant. The labs that we typically send out are anti-tissue transglutaminase IgA, as well as a total IgA in children that are 2 and over. For children that are younger than 2, we would send off those same tests and include an anti-gliadin IgG. The reason for sending off the anti-gliadin for under 2 is that the TTG is less sensitive and specific in the younger kids. But when they're 2 and older, the TTG alone is a very good test, meaning if it's negative, it's very unlikely that someone has celiac. If it's positive, it's very concerning for celiac disease. The reason for the total IgA is that if someone has IgA deficiency, the TTG IgA is less reliable and you'll need to send off that anti-gliadin IgG. So we often in these, when parents see the lab results and they see that an IgA is elevated, that is not something that we're concerned about. We're sending it to screen for true IgA deficiency, which is usually a total IgA of less than 10. Interestingly, children who have true IgA deficiency are at risk for getting more GI bugs and more other infections. And so, sometimes we actually catch true IgA deficiency and actually send them off to immunology for some counseling. At this time, celiac disease and EGD is still recommended for diagnosis. Just a tip, we do want these patients to be on a gluten-containing diet at least 4 to 6 weeks before an upper endoscopy. So it's important that if you're sending these referrals in, that you're not telling the family to go ahead and change their diet. What is a gluten-containing diet? It's a diet that has at least 1 slice of wheat bread, roughly around that quantity per day. We do have a good triaging system so that patients who have abnormal TTG are being fast-tracked, so these patients are not waiting for a long time to wait for their scope, because often they're still having lots of symptoms. Gluten-free diet is still the only treatment option at this time, which does work. And of note, celiac is associated with other autoimmune diseases like thyroid issues, autoimmune thyroid issues, as well as type 1 diabetes. We often diagnose new celiac disease in type 1 diabetics, and when patients are diagnosed and treated for celiac, they actually have better glucose control and do better. Other metabolic disease I mentioned, hypothyroidism, so we send off a screening TSH, and if it's abnormal, it reflexes to a free T4. If the free T4 is normal, it's nothing to worry about. Lead toxicity, just wanted to put that in there. So risk factors include ingestion or retention of foreign body containing lead. We have much less lead toxicity now since lead paint has stopped in 1978. Some patients to think about, you can also get lead toxicity from, interestingly, bullets or other foreign bodies that are retained. So that's just something. So separate from those things that I mentioned, constipation is largely functional, meaning it's some of it is associated with, and we'll go over this, diet, water intake, and habits around stooling. The diagnoses I mentioned on the right are a host of diagnoses where we see a lot of associated functional constipation. So, for example, connective tissue disease like Ehlers-Danlos, very common to have associated constipation. Patients who have significant neurological impairment with diffuse developmental delay, so severe cerebral palsy. Patients, and think about some of these kids who have decreased movement and they're not getting the effects of gravity, which help with stooling quite a bit, and so they can suffer from more constipation. Children who are tube fed also get lower fiber intake in general. Um, when they have low pelvic floor activity, they also have decreased tone in the core and the abdomen, which is a very important part of um, normal stooling patterns. And we see in these these neurological diseases acquired dysmotility for the gut, and it's not truly a motility disorder. So in these categories, we still would treat this as functional constipation, meaning adding in medications to augment the function of the gut in order for these children to have normal bowel movements. We can also see a gradual decline in patients who have myotonic dystrophy or muscular dystrophy, spinal muscular atrophy as well, and also mitochondrial disease. Your entire GI tract requires all the activity of the mitochondria. So just as every cell in the body is hit, so is the gut as well. So let's talk about constipation in an otherwise healthy child. So with an otherwise healthy child, it's these main three factors. It's water intake, dietary fiber intake, and behaviors around stooling. Let's talk about water. It's really important to normalize what is good amounts of water for kids, and I've broken it down by cups versus ounces. And if you look at this chart, it's actually quite a bit of water. I don't even think adults drink that much water, but it shows you how little water our kids are probably getting and how much better that they can do. Um, what's really helpful when I explain to families is that your colon a uh, is on autopilot all day long, sucking water from the stool, and it does it nonstop, and it will do it as intensely as it needs to bring back water to the body. So if you are baseline dehydrated, it is going to make your stool drier than if you were well hydrated. The other piece to that is the longer the stool sits in the colon, it'll continue to get drier and drier because the colon is on autopilot, sucking water out of it. So I talk to families about how important hydration is, and really emphasizing that kids should be drinking multiple cups of water per day. For the younger kids, I tell them drink a glass with every meal and a glass in between meals. And then for the older kids, why you see such a big range for the older kids is also activity dependent. So if you have a kid who's very active in sports, they should be drinking way more water than the kid who's less active. In addition to high water intake, you want to limit the other fluids. So limiting the amount of milk intake. We have a lot of kids who are drinking excessive milk. There's lots of parents I hear about where kids refuse to drink plain water, and so they only want to drink something that's flavored. I try really hard to explain that there's really no other option other than to drink good old plain water. Some limitations on milk: 2 to 3 cups a day. General pediatricians I know are all out there talking about avoiding juice and taking fruit instead, avoiding caffeine and artificial sweeteners. There are a lot of things on the market that are flavored waters, and they are really not helpful. I talk to families about how there's still additives in there, the artificial sweeteners that are in there. For example, I don't know if anyone's seen, there's this item on the market called Circule, and it's these cartridges that add flavor that have no calorie, and they say there's no additives. However, when you look very closely, there is sucralose there, which is not good for you to drink a lot of. So I really just tell parents without negotiating that water is the best, and we should not be having them drink things that have flavor. Fiber intake. So looking on the left, the chart there, I don't know how many parents actually realize. I have so many parents in clinic that insist their kids are eating plenty of fiber. But if you actually give them a sheet that breaks down how much fiber are in foods, I'm not convinced they'd be able to say that they give their child that much fiber. So if you're looking here, we're seeing 1 to 3-year-olds are 19 grams of fiber a day, 4 to 8-year-olds 25, 9 to 13 26 grams, and the bigger teenagers 38 grams. This is a very small list, and I just thought it would be helpful to bring this type of list. A cup of blueberries is 4 grams. One pear is only 4 grams of fiber. Half a cup of cauliflower has 1.78 grams. Half a cup of Brussels sprouts, 2 grams. A tomato, 1 gram. Half a cup of green beans, 2 grams. And 10 cherries only have 1.3 gram. And I highlight the slice of bread because I also see parents that tell me, well, we eat lots of things that say they're whole wheat and they're extra wheat. Even foods that say they have high fiber are actually very low in fiber. I tell parents that they should not count any of the carbs that are advertised as high fiber towards their daily fiber intake, and it really should come from fruits and vegetables. I also hear a lot of parents say, my kid doesn't like vegetables, but they'll do lots of fruits. And that's really a time for me to sort of help with the parents and explain to the kid that vegetables have way more fiber than fruit. And although fruit is very good for you, it should not be the only source of fiber. So, giving them the education, giving them perspective that they have work to do is helpful for them to understand why their child may be constipated. So I start with this education. Another tool that I give families is to give extra fiber. So a lot of parents are using fiber gummies. Fiber gummies are fine, except that they also are low in fiber. Each fiber gummy usually has about 2 grams in some of the brands that I've seen. So I prefer to recommend Benefiber powder or Nutrisource powder. These are both fiber supplements that are prebiotics as well. 1 tablespoon usually has 5 to 6 grams. So to supplement daily fiber intake, they could be taking anywhere between 2 to 4 tablespoons of the powder a day. It's very easy to mix in any of the water that they drink. It dissolves immediately, so it's nothing like Miralax. The only thing I'll counsel families about is if you have one of those kiddos that doesn't like the way, they're very particular about the way something looks. I tell them to mix this in a water bottle that's not see-through. It does make it a little bit almost like there's a drop of milk that went into the water bottle. So a kid may see that and find that really off-putting, but it doesn't have a texture. It does not have a taste. And so this blends in really smoothly. Limiting factor for taking too much fiber is just gassiness. So I tell parents you just keep giving them multiple spoons until you find that they are gassy in a way that's negatively impacting them. But no concerns about good fiber intake. And the fiber supplements, in addition, like I mentioned, are prebiotics, so can also help with any dysbiosis that's also occurring with their gut. Behavioral management. This is so, so important, and it's very important for us to reach our families in this way and try to help them understand. So, a couple things. Withholding behaviors, very important to tease out. Instead of asking directly, does your kid have withholding behaviors? I'll ask, they will first give me the history that their child is trying really hard and it's really upsetting for them. They cry, they turn red. And I ask more detail. I say, what else is your kid doing when they're trying to poop? And these are usually some of the younger kids. What is their body position? So parents often will say their kid's not withholding and they're trying really hard, but then they'll describe to me that their child is standing on their tippy toes, hiding. These are all withholding behaviors, and I want to help destigmatize that it's blaming. I tell parents that kids are not intentionally trying to avoid pooping. Um, Pooping has been unsafe, uncomfortable for them at some point, and this is a natural instinct for them to do this, and they're not doing this on purpose. And so that sort of helps them understand that we need to buy into using medication to help us, and we'll talk a little bit more about withholding behaviors and why we use medication for that. One thing is if you're having a difficulty getting a history of withholding behaviors and you're also having difficulty getting a family to buy in, and I don't know how many community providers have access to SITS markers, but this is something that's more like a poor man's motility test that we use, and it's nice for a couple reasons, and let's talk through what a SITS marker study is. So SITS marker is a clear capsule that has little radio opaque rings in it that are soft and flexible. So if you took it like a capsule, it would just go into your stomach and make their way. It's about 24 markers, and they make their way through the GI tract. For younger kids, you can open the capsule and put it on a spoonful of pudding or whatever the kid will eat, and it accomplishes the same thing, and they're going to make their way through. What you do is you give them the capsule ingest in one way or another, and you're taking an x-ray 5 days later. If the markers are evenly distributed throughout the colon, the majority are still retained after 5 days, that does suggest that there's delayed motility, right? Because it's making their way through, but they're going through slowly. If most of the markers have been retained in the rectosigmoid, that is consistent with withholding. Everything's moving properly, but all the markers are ending up in the rectum because the kid is avoiding pooping. If all of the markers have gone, then everything has been moving in a normal pace. So we use this I use this test to understand, is this a patient that I need to think more about a motility test and motility treatment versus a kid who I need to put on a more significant regimen for stooling with more stimulant laxatives for withholding. And honestly, sometimes we use this for kids who tell me that they haven't stooled in a month, and I can feel on physical exam that they're going to the bathroom because I can prove with this test that they are definitely going to the bathroom, even though we have these teenagers that tell me that they don't poop for a whole month. So the SITS marker is an easy thing to do, and it gives helpful information to help you move forward. So I just wanted to talk a little bit about that. And again, I'm not sure if you guys have access to a SITS marker in your clinics, but it's very easy to do. The big part about behavioral management is instituting toilet time. So toilet time, I focus on 1 to 2 times a day and no longer than 10 to 15 minutes. Sometimes you'll see other providers may say toilet time 2 to 3 times a day. I think it's really important to be realistic. We're all parents or caregivers in some way, so we have to give our parents tools that make sense and that are feasible. The bathroom should not be a place of punishment. And so 1 to 2 times a day is a realistic time period, and they shouldn't be sitting on the toilet for an excessive amount of time because oftentimes, again, it becomes onerous or they're doing other things that aren't actually paying attention to focusing on their body and trying to stool. Toilet time should be after meals. We want to take advantage of the gastrocolic reflex. After eating, it's a normal time that things are starting to move. Parents, when I tell them this, they understand this. And then pick a time that makes sense for the family. So, for example, I ask a lot of questions about what their kid is like in general. And things, these types of questions are like, does your child tend to avoid public restrooms? Will your child go to the bathroom at school? Do you guys typically wake up in the morning and head right out to school and work immediately? Do you guys wake up way in advance? After school, does your kid come home after school or go to an after school program? Is there some downtime after school at home with you? Those are the type of questions I ask because that's how you decide for them what's the best toilet time. Kids that avoid public restrooms would benefit from a first morning bowel movement and toilet time in the morning. That does require that the family is waking up significantly in advance, taking the time to eat or drink something to get things moving. I often encourage those patients to drink a cup of cold or warm water, which stimulates the gut even more, and then time to sit on the bathroom where they're not rushed, and then they can get dressed and get ready for school. Having a bowel movement before school takes away all of that cramping that can happen throughout the day when they're avoiding pooping at school. Kids who don't really care about where they go to the bathroom, but morning is very hard. After school snack time is an easy one. After dinner is also a very relaxed time for some of those kids. So that's how I help the family understand. When they pick those times, I tell them this is what you're going to have to establish as a schedule. This is what you should stick with always. You do this when you're home. You do this when you're at grandma's house. You do it on vacation. It's sticking to a schedule. And you'd be surprised, there's lots of families that don't think that children need to be put on a schedule, but as adults we know that schedules for bathroom time work really well, so the kids work exactly the same. So I tell families, if you ever want to get off of medication, you have to make this change. Some of our families, they also ask for a note for access to a private bathroom at school. Kids refuse to use public restrooms because you'd be surprised. There's some pretty bad situations at school. I'm sure you guys actually hear about that. You should hear about it probably more than I do. Kids refusing to go to the bathroom throughout the entire day. So one of the only breakthrough things is for them to have access to the nurse's bathroom or a private bathroom at school, so they feel like they have a safe place to go to the bathroom when it's time, and a point system. So whatever the age is, a point system, and I recommend parents reward the willingness to sit first of all, and a second additional point for actually having a bowel movement on the toilet, so that they're getting reinforced for both behaviors and actions. I say to parents, use a point system to earn time with you or an activity. Um, these are long-standing problems that take a lot of time to fix, and so if parents are using point systems to buy toys, it's not financially sustainable, nor is that very effective. So I encourage parents, whether that's they earn iPad time or going to their favorite park that's a little bit farther of a drive with you on the weekend, those are the type, or going to the museum that they haven't gone to for a long time. Those are the types of things that we should be using those points for. Um, I see a lot of parents who use iPads on the toilet, and I discourage that. They need to earn the time and then get the iPad afterwards, because otherwise kids are smart. They'll sit there forever and use the iPad. I wanted to take some time to talk about fecal incontinence. So, fecal incontinence is secondary to severe and chronic constipation. So, this definitely is something where PGI can really help these patients, and it warrants a full consult, because these patients need us to think fully about everything, because it's gotten to this extent and it's very severe, and also some long term guidance and management. Um, we start with the bowel regimen, which I'll go over, and we will also, for the most severe cases, also provide access to our GI psychologist for these kiddos, because they are the most severe, often very anxious, and so need a lot of support on working through their anxiety and compliance, and the parents require a lot of coaching. We currently do not have a GI psychologist. Our GI psychologist has been gone for about 6 months, and we are hiring and looking for our next replacement. But this is a type of patient that would definitely get in with our GI psychologist. Um, I like to start with a possible clean out, um, followed by rectal meds for 4 to 6 weeks. And I wanted to introduce, and these are tools that I also, I don't expect pediatricians in the community to handle fecal incontinence on their own, but I just want to put these out there, that these are also helpful tools for any type of constipation that you're trying to help. I tend to avoid enemas. Enemas are really traumatic for kids. They don't hold them for long enough periods of time for them to be useful. And so I tend to use suppositories because I get more buy-in, and they're better. So you have a couple of options up here. On the left is Enemies, which is docusate, rectal docusate, and there's a kid version, so it's 100 milligrams. And this is works very quickly. The one on the upper right is a liquid glycerin suppository. This is much preferred for me in anyone that's over 1 year old. It's a very small volume of glycerin, and the bullet glycerin suppositories really are not that effective, very well tolerated because it's very low volume. And the one on the lower right is your bisacodyl suppository, which is 10 milligrams. You can use half of a suppository. Parents have told me that it's easier if you cut it down the vertically, in order to use half of it, but you can use half to a full. When these all go in, they do not cause any discomfort, so are much better tolerated for kids. Um, because they're low volume, they can take anywhere between 15 to 60 minutes to work, so I definitely coach to parents that you should not be in a rush to go anywhere if you're using this. How do I justify rectal therapy for these patients? So by the time I've gotten these kids into clinic for fecal incontinence, compliance is already a big challenge. And so prescribing them a big oral regimen to get things going is can be harder. Often with oral regimens, when they're that severely constipated, there's lots of back and forth. There's too much tinkering about the doses because oral medication is just not one to one in terms of how you prescribe it. Every kid is different, how much they need and how they respond. Whereas rectal meds are like 90% plus effective. I use a suppository, I get a result, and so just much more effective, which helps me with buy-in for the kids and the families. Like I mentioned, I stay away from enemas because they tend to be traumatic and difficult. Um, I emphasize to parents that are not thinking openly about rectal meds that cleanliness is for these kids is how we're going to succeed with them. When kids have um, daily output with rectal med, and we're seeing that every day, we're going to consistently see no incontinence and no leaking. And that's going to set us up for success when I switch them to an oral regimen. The other thing that helps parents a lot is we talk about incontinence destroys their confidence and exacerbates underlying anxiety. The parents know this themselves. They will tell me that the kiddos are not ever telling them that they're having an accident. They're sitting in it, but the parents can clearly smell it. The friends can clearly smell it. And so, we have to choose between allowing your kid to be without accidents, be able to feel good about themselves, and not live sort of in this. They're almost like they kind of have blinders on about what's going on with their body versus keeping them clean and letting them build their confidence, work on their anxiety. And it's just a bridge until I use an oral regimen. Then I go on to, for these kids, once I've gotten them to stool consistently for 4 to 6 weeks, by and large, most of the kids that are using these daily regimens, they are not having accidents anymore because they are always emptying. And so there's nothing to leak. And after they've succeeded for 4 to 6 weeks, we switch to an oral regimen that consists of a stimulant laxative always combined with a stool softener. And the reason I introduce what I do with fecal incontinence, because this can also be carried to other kids that you're treating even for less severe constipation. In terms of a stimulant laxative, you have three options: bisacodyl, senna, or sorry, two options: bisacodyl or senna. Those are really your two options for more severe constipation. For bisacodyl, you can use 5 to 10 milligrams daily. It only comes in a tablet form, and you'd actually be surprised how young kids can tolerate bisacodyl because the tablets are so small they can learn to swallow them. One thing that I want to note is that I have had patients complain about nausea with bisacodyl. Senna at 1 to 4 tablets daily. This can be associated with more cramping, and I often say to parents ahead of time, cramping is not a bad thing. That's how this medicine works. It's pushing the stool out, and so that cramping sensation is part of how it's working. Sometimes the cramping can be really severe if kids are withholding. I tell the parents this is a moment to talk with your kid about the body is trying to tell you something. It's time to poop. So let's go sit down and try. Of note, you cannot crush bisacodyl or senna in the hard forms. It's enteric coated. It does not work very well, so you should not be crushing these tablets. Senna has multiple options. It has tablet form, liquid form, and the X-Lax chocolates. Of note, tablet is, even though the same dose, is stronger, more effective than liquid, and liquid is stronger, more effective than X-Lax. So I put out sort of these equivalents. So 1 tablet is equal to 5 mLs of liquid, which is equal to half an X-Lax square, but they are not exactly as effective as one another. Timing of the day. It's typically dosed, it says on the box, before bedtime, but you can adjust depending on the goal. They take 6 to 12 hours to work, and so if your goal is to get them to stool in the morning, before bedtime dosing works. If you want them to stool in the afternoon, you can do a morning dose. So it really depends on what the family needs. Always do stimulant laxative with stool softener. So one thing I see is sometimes providers will do excessive, just keep upping the dose of Miralax indefinitely until you get the desired effect. And that's why doing a stimulant laxative is helpful in combination with a limited Miralax dose. Excessive Miralax dosing leads to sort of frequent leakage every time a child sits on the toilet. To them, they see that as diarrhea. They see that as undesirable, that they have a little bit of poop every time they sit on the toilet. So it decreases compliance. In addition, excessive Miralax dosing can lead to lots of gassiness and even more cramping for the wrong reasons. So I always say limit it to half to one capful and do the dosing once per day. Try not to split the doses multiple times a day. Also discourage sipping on Miralax dose. Some parents will put it in the water bottle and the kid will drink it throughout the day. Not as helpful as taking it all down in one dose and one sitting when you're just drinking the cup of something to drink. I have a lot of kids who refuse Miralax because they insist that it tastes gross. They can see the texture. You can advise the family to mix it out of the sight of the child. They can mix it ahead of time and put it in the fridge. It dissolves very nicely. Parents often make the mistake of mixing it right before they give it to the child. That's not a good idea. Zero buy-in. If a child or a teenager absolutely refuses to do Miralax, Docusate is a nice option. They do need to swallow capsules, but Docusate is equivalent, the pill equivalent of a Miralax. It's just a stool softener and will work just as well. And I have good compliance for the teenagers who refuse Miralax. So just, I want you to, this is what I use for fecal incontinence, but this applies to any of your chronic constipators to think about some of these doses. Long-term treatment, before I move on to general constipation regimen. So for our kids who have incontinence, I typically will do a 4 to 6 week plus or minus a clean out regimen of rectal meds. I'll move them on to a stimulant plus softener oral regimen. And I do not make any adjustments to the dosing for at least 6 months. They need to be stooling daily for 6 months without any accidents before I even think about weaning them. And I tell the parents, this is your time to make all the changes that we've talked about in order for you to have success off of stimulant, laxative, and stool softeners. Lifestyle changes do not change in a heartbeat. They take many, many months to change. And so parents need to really be actively thinking about it if they want to get off the medication. Parents also need to be quick to return to rectal meds at any time when they get backed up, there's an accident, instead of letting it progress for a long period of time. And that's what I'll say sort of about fecal incontinence. But these are patients who really could benefit from Pete's GI. Back to treating chronic constipation. So I want to break this down. So first thing is to start with daily dose of Miralax for 7 days. And I say that with a caveat of, if this is a kid who stools, has constipation, but generally doesn't have issues around toileting, doesn't have withholding, but is constipated, you can start with just daily dose of Miralax for 7 days to see how things work. If that is enough, then you can continue this for multiple months. And again, at this point, I would tell families that until you're stooling consistently for 3 to 6 months, you should not be coming off of that Miralax dose, because while they're taking Miralax, they should be implementing all the things: increase water intake, increase fiber intake, changing habits around stooling, because they will not succeed without those things to come off the medication. If with 7 days of Miralax alone, they're not stooling daily and it's not Bristol type 4, you can add a stimulant laxative in addition to Miralax. We'll go over those doses once again for the stimulant laxative. At this point, are things going well? Then you can go to a maintenance regimen with a softener plus or minus a stimulant. And that's where the maintenance phase is, where you're saying we're going to stay with this for 3+ months. And again, if after that they are still not going well, then I recommend doing a clean out. After the clean out, then you go back to a daily softener and stimulant. And this is very important because I see a lot of, because I know we have our toolkits on child, but it's common that I see families will come to clinic and say they need to clean up, but they're not maintaining on anything. very important that if you're at the point where you're recommending a clean out, that they do the clean out and continue a regimen afterwards, because the issue is not going to resolve itself after just a few days of a clean out. So I want them to be on some sort of a daily softener and plus or minus a stimulant for a sustained period of time. The other thing that's important, because a lot of the symptoms of belly pain, distension, all of that is not going to get better right away. And that's hard because that's what families are looking for to buy into further treatment options. So it's important to sell to them that even after a clean out, you could still have belly pain and cramping, and we need to get on a regimen for a prolonged period of time to see if this works. So this is my chart dosage, and I believe we're going to send this PowerPoint out for you guys. This is our dosing regimen for, this is again the first phase when you're just doing daily Miralax to see how to get things going. The chart I recommend for dosing. So when you're moving on, if that doesn't work and you're moving on to adding a stimulant laxative, I break it down into 3 groups. So preschool, school age, and more adolescent. And this is essentially focusing on senna, and I added bisacodyl for the teenagers because the assumption is that they're able to take those tablets and more willing to take those tablets. And these are the equivalent doses. And if you guide it, but if you focus on just the senna dose, it helps you extrapolate the other doses for the other formulations of senna. So I would say if you focus on half a tablet to 1 to 2 tablets daily, it helps you remember that. In terms of a clean out, so these are our recommendations for our clean out, and this is not listed on child. So this is more clean out that we use for when we're going to do a colonoscopy. I find that the recommendations we have on our toolkits focus on multi-day cleanouts, which again, I don't find that those are practical. I don't find that I would want to stay at home for 7 days cleaning out my child, and so I don't think that that's efficient or effective. And again, we're trying to get buy-in from our families that this is a step that could be helpful. So I usually recommend that we do a clean out over a 2-day period. So the general gist of a clean out for a bowel prep is 2 nights of a stimulant laxative and 1 to 2 days of high dose Miralax. So for the 2 nights of stimulant laxative, we're using the same dosing table I gave you before for stimulant laxative. And for the 1 to 2 days of Miralax, preschool kids, 1 cap of Miralax 3 times a day for 2 days. For the school age kids, it's 1 cap of Miralax 4 to 5 times a day for 2 days. And for children that are older than 12, they can actually tolerate quite a bit. 14 capfuls of Miralax and 56 ounces. The easiest way to give them the instructions for this is 2 capfuls of Miralax and 8 ounces of liquid, and they're drinking that all day. In terms of what to do about their dietary intake, they're going to have a more effective clean out if they eat a light diet. So since we're not cleaning out for a colonoscopy, they don't have to do all clears for the clean out, but they're going to have a more productive clean out if they focus on soups and porridges. That's often what I'll tell parents. Instead of doing heavy meals that have lots of meat and lots of starch, the soups are much better. So that's what I would say about that. In terms of maintenance, so after you clean them out, it's really important to transition to a maintenance phase. So if you feel like this is a more mild case and you want to just try a stool softener, again, I would just do once a day dosing of either Miralax or Docusate. If you think a patient would benefit from a stimulant laxative, one, by severity and chronicity of the symptoms, I would consider it. If you have a child that withholds, if you have a kid who you suspect from the way they are that they're less attentive to their bodily signals or don't want to stop what they're doing, stimulant laxative is very helpful to keep them on track and on target. I added here magnesium oxide and hydroxide because this is something that is somewhat helpful for some kids, but I also like to advertise it because parents are often turned off by bisacodyl senna. They're really worried about it being a medication, and magnesium seems more natural to parents. Magnesium is nice, again, as a stimulant, It is something that I will transition to after we've used bisacodyl and senna, or if magnesium is the only thing that the parents are willing to try. Kids would need anywhere between 2 to 800 milligrams a day. Generally, I recommend 2 to 400 milligrams for most of the kids that would use magnesium, and 800 milligrams only for the bigger kids like adolescents. Um, it limiting factors for this is cramping and gassiness and explosive stools. Um, Lots of options out there. Pedialyte brand has a chewable option out there, and um, there's lots of forms, honestly, of magnesium, milk of magnesia, mag citrate. There's lots of options. Take home points. Review what is reassuring about your patient to their families. Whether that's your kid has a normal exam and doesn't have any pain on exam. We've done a set of labs, your kid's growing well. So focus on the positive about a kid, and because those are lots of things that we would not see in some of those red flag cases. You can review that there are limited diagnoses that we could be missing, like Hirschsprung spinal cord issue, celiac thyroid, and why you don't think their kid fits into that category. I talk a lot about that 80 to 90% of the constipation we see in our clinic is functional. And what we're going to come back to is your child needs to implement these lifestyle changes, and we need to use medication to help. And really talk about the long-term treatment is lifestyle changes with medication as a support medicine is not a bad thing. Thank you for inviting me. This is our wonderful division, and this is my email contact. I think I went a little over time, but I'm ready to answer some questions.
Awesome. Thank you so much, Dr. Padamanouch. We do have a few questions in the chat. While I read those out, just a reminder to all of our attendees today that you can either put questions in the chat or you can raise your virtual hand. That's the button that looks like a hand, just to the right of center of the bottom of your screen. As a reminder of everyone, or just so you know, I am not clinical, so if I accidentally butcher what you are writing as physicians speaking to each other, my apologies. Our first question is from Jean. For patients with elevated TTG-IgA, I believe that's a lab of some sort, and pending GI consult, usually 1 to 2 months, and significant symptoms, can parents initiate strict gluten-free diets, or would you prefer them to still be on gluten when you see them? It's challenging when parents want the definitive diagnosis, but we also want these patients to be feeling better as soon as possible. How would you navigate this with a parent?
Yes, we and Dr. Lee is the head, so the lead for the medical director for our celiac program, and he also has APPs that work on his team, and they have specific slots just for celiac patients. So the goal has been to triage these quickly and get them into those specific slots so that these patients are not waiting. We definitely don't want these kids to be waiting for multiple months on a gluten-containing diet. But yes, we do want them to be on a gluten-containing diet and not to change their diet while they're waiting. If they're having severe symptoms, then it can be escalated through our e-consult, and we can shut those over to Dr. Lee to get them in earlier. If the wait time is 4-ish weeks, I think that is still appropriate for a non-severe case of celiac with an abnormal lab. But yes, we do want them to be on a regular diet before they get to us.
And just a plug for anyone who's not familiar with e-consults, you can go to our website, seattlechildrens.org, under healthcare professionals and sign up for an account with Epic Care Link, and that is the medium by which you can submit an e-consult to not only GI, but many of our other specialty programs at Seattle Children's. Next question from Shakita Bell. Can you speak more on constipation in children on the spectrum? I imagine there is some behavioral and intake links. Any anatomical or other considerations? How about with treatment? Do you alter your approach or have other tips or tricks?
I'm assuming you're also referring to that some of these children who are very restrictive about the things that they'll take. Is that what you're asking about? Different options that we have for kids who are very difficult to get them to ingest medication options?
I don't know if she gave a thumbs up.
So yes. Okay. That is can be very challenging in terms of, so we do think about them very similarly, and you're right, it is because of the food that they're taking in. They often, some kids who are on the spectrum have very limited food choices, and they are eating very minimal amounts of fiber. Um, those are the parents that I will ask them, give them the tips of doing Benefiber. Benefiber can still be hard because these kids are very careful about looking at the types of drinks that they're drinking, and can sense any type that the time the food has been altered. You can also add fiber to anything that you're cooking. So even just to be creative, you can sprinkle things on foods or mix them in things. So it's not just water that you can mix them into. Um, and for those kids, I do sometimes recommend, if you want to water things down, to get them more water. In terms of medication, most of the kids are okay with taking Senna in the form of X-Lax, and so I usually don't have a problem with that. Magnesium has, because it has so many options, I will talk through all the different possibilities to see if there's something that the patient will take. For example, Dulcolax has chews that are kind of like candies. Um, MagCalm is another form of magnesium that you can mix in with water that tastes like fruit. We also have milk of magnesia. Interestingly, some kids will drink quite a bit of that and be fine. And then as a you can't do this every day, but even Epsom salt baths, sometimes you can get magnesium. So there are ways to get temporary relief. I would not recommend Epsom salt baths every single day. But if you do an Epsom salt bath, like with a regular drawn bath, and you're putting no more than 2 cups of the Epsom salt in the bath, they can actually absorb the magnesium through their skin and get some benefit. So those are a couple of the tricks and tips I have for that population.
Great, thank you. Next question we have, can you speak to treatment of functional constipation in children under 2?
So for children under 2, I use X-Lax quite a bit, and most of those kids will take that. But again, this is a population that you're really trying to tease out if there's withholding or not. Um, Most times, if they have significant constipation, I first off discourage parents from trying to do any potty training. These are not good kids to do an early potty training with because there's already lots of stooling issues, and it'll just create more of a power dynamic. That's number one. I really, like I mentioned before, get a really good history about whether or not there's withholding behaviors, and then those are the kids that I'm quick to recommend Senna, and most often for these kids, it's in the form of X-Lax chocolates because that's the only form that they're willing to take. Um, there is much more we can do from a water intake, and fiber is usually not too terrible in this age group, but we do spend some time educating about fiber for those kids. But the biggest thing that I see is withholding and trying to use medication to assist us. Another thing, this is another sensitive population where I try to destigmatize and take away the blame. Parents are very sensitive about that and want to explain to them that it's not intentional when the kids are withholding. This is really the population where, it's just a negative experience, and we just need to kind of make pooping safe and comfortable again for them, which is why medication is very, very important to add.
Okay, we have a few more questions if you still have time to stick
Yeah,
around.
yeah.
Okay. What are your opinions about using a KUB to help with diagnosis of constipation when parents do not believe their children who are having pain or leakage are suffering from constipation?
So he'll never tell me that that's the way we diagnose constipation, because the truth is it's really about the clinical history. It's about what we feel on physical exam. But I do understand how it's the utility of a KUB. It's not one of those things that I recommend that every time a patient comes to clinic, we continue to get a KUB to diagnose. And that's what I would help coach the parents through, is that we're going to take a picture to get an understanding right now, but this is not how we decide if your child's constipated each time. To sort of pre-coach them that this is not the only diagnostic tool to understand constipation. I think helpful to build why you already think the child is constipated based on the story you're getting, and if a KUB helps them objectively feel that you are correct, it's really nice. It is nice for the kids where we're trying to understand, is this a patient who needs a clean out? Is this a patient who needs some rectal meds to start a clean out? Because if you're able to identify that there's a really large stool ball in the rectum, it'll help guide, really, it would change your management plan. A kid who has a high stool burden but not impacted, you could just do a good bowel regimen or a clean out to start with, a good bowel regimen to follow. A kid who has a really significant stool ball on the bottom on the KUB would really benefit from rectal meds, and that you could counsel the parents. I really think you would be better off if we did, 3 to 5 days of rectal meds and then do a clean out afterwards to get rid of the plug at the bottom. So I do think KUBs have a place and they are valuable, but I just try to make sure parents understand that it's not going to be the only way that I get information. And like I said, we do use KUBs for those SITS marker studies, which are really nice.
And I think last question, at least for the moment, at what dose of magnesium citrate would you be concerned about electrolyte imbalance, or for how long of a treatment? And do you ever run labs, and at what point?
With the dose of 400 milligrams for most kids per day, 200 to 400 milligrams, it's very unlikely for you to have any electrolyte imbalances. So I do not, if I'm recommending a low dose, I do not test for any electrolyte abnormalities for these patients. I would say that if it's helpful to counsel families that if a patient is having vomiting or diarrhea and dehydration, that they should stop a supplement. But I think most parents would do that anyways, especially if they're sick with a GI bug and they don't want to make their diarrhea worse. But with those low doses, it's very safe, and you're unlikely to cause any issues. I forgot to mention mag citrate as a clean out tool. And actually, I'm going to go over that really quick because it's a really neat tool. So mag citrate was recalled for a time and it should be back on the market. But mag citrate for the families and patients that are willing is so much easier than some of the clean out regimens because it's more straightforward for families, and it's quick. So the rule of thumb with mag citrate clean outs is 1 ounce per dose per year of life to a max of 10. So each bottle of mag citrate is 10 ounces. And so, for example, say you have a 7-year-old patient. Each dose would be 7 ounces, and they need to take 3 doses, and that is the entire clean out. And you can see if a family is willing to do it and a patient is willing to do it, that is so much more straightforward to explain than giving those recipes that are even in my PowerPoint. It's very confusing, all of these steps, and that's a huge challenge we have with our families, is explaining how to do these regimens, helping them, guiding them through it. Mag citrate is, if they purchase it over the counter, it's relatively cheap. And the way I dose it is morning, evening, morning. And that's your 3 doses, and it's done. Very straightforward. So if you were, another case is 18-year-old, because the max is 10 ounces, you're doing 3 bottles of mag citrate, 10 ounces, 10 ounces, 10 ounces. And it is a very great clean out, with very clear instructions that are pretty straightforward.
Okay, thank you. All right, well, that looks like all of our questions. So thank you so much for the talk today. I think it was great to listen to, certainly for myself, and I imagine all of our partners in the community found it incredibly helpful as well. For anyone who's still on, I did put a link to the evaluation in the chat. We very much appreciate your feedback. I will be sending a link to that out this afternoon as well, just in case folks had to hop off. And as a reminder, in about a week, we will follow up with a PDF of the slides, as well as a link to the recording of this session if you would like to review or share with your colleagues. So hope you all have a great afternoon, and we look forward to seeing you again soon.